Hello everyone, and welcome to this, our first meeting of 2021. My name's Conor Reddy, and I'll be chairing tonight's meeting. So I guess I'll start by saying that I guess we'd all wished we'd enter 2021 in better circumstances, but unfortunately we're in a very dire situation indeed. I guess an unprecedentedly large surge in COVID-19 infections has brought an already overstretched and under-resourced public health service to breaking point. So we're very lucky tonight to be joined by Phil Nehay, the General Secretary of the INMO, who's going to discuss a little bit about what the INMO have called for in this particular moment. Just before I bring Phil in, I'd like to make a quick clarification, and that's just to say that the Campaign for an All-Ireland NHS and the INMO are two separate organisations. We obviously share the objective of universal access to healthcare for everyone, but the union itself at the minute does not formally affiliate to the campaign, and neither does Phil. So she's very kindly joined us tonight to speak, but I just wanted to make that clarification in advance. So Phil's going to speak for a couple of minutes here, and then we'll be joined hopefully by our other speakers. But we will have a bit of an opportunity to take questions for Phil. So please do get them in the comment section wherever it is you're watching. So without further ado, I'll hand over to Phil.
Thank you very much, Conor. I suppose, like you say, I was invited to speak on the issues facing nurses and midwives at this time, and I'm happy to do that. And as you say, obviously the campaign is separate to us, and obviously we're not affiliated to it. So I suppose the issue that I wanted to really reinforce to the people who are participating and listening tonight and this evening, and thank you for logging in, is first and foremost, as you've heard, the figures in, and the admissions to hospital and the high number of deaths again today, which is very sad and very unfortunate. That is against the background of a low enough staffing level to begin with in our acute hospitals. And that means that the pressure upon those who are at work is increasing, and they're doing their best. But they're working in extraordinarily difficult circumstances. And when you combine that with the number of illnesses and the infections and the outbreaks now that we're looking at, and today the figure has increased again to just over 18,000 healthcare workers themselves infected with COVID-19 since this pandemic began. And that's a huge number. And that's across all grades, obviously, but we do know from the stats that we get on a daily basis from the Health Service Surveillance Centre that the highest number combined is the nurse, midwife and healthcare assistant. So they are the grades that are facing the patient, and they are obviously becoming infected at a higher rate and a faster rate than anybody else who's working in the public health service. Or indeed the private health sector. So unfortunately, that then depletes rosters and makes it more difficult for those that are at work to provide the safe care. That's one issue. The second issue is capacity. We still have a trolley count. We continue to count trolleys on a daily basis. They're much lower than last year. Last year was, I suppose, a very busy winter. January, particularly, every year is very high from a trolley count point of view. But at this point in the pandemic, we shouldn't have anybody in an acute hospital if there isn't a bed for them, because that is obviously going to be a situation where cross-infection and the spread of this virus is going to be even more difficult to contain. So trolley counts shouldn't be happening. The wait for discharge from an acute hospital, we understand that figure has increased again. So we know we have a problem in our long-term care facilities. They have, for a variety of reasons, they're unable to take admissions from the acute hospitals, which increases the numbers in acute hospitals who are actually medically discharged, but they can't go home yet. They need that interim piece. So the perfect storm, you then have a pandemic. So what we have been calling for as a union, representing those that work across the public and private sector, is the implementation and the full implementation of Sláinte care. We have gone, I suppose, to great lengths to look at Sláintecare, to look at and to contribute to submissions that were made toward it. We are critical of the slow pace of delivery of Sláintecare. For example, we believe that care of the older person, which is now 82% of it is privatised, that's the wrong model, that we should be investing in public healthcare for our elderly population to ensure that it's there when we need it, that it's staffed properly, and that we don't have situations like those that arose in the pandemic, where staffing completely collapses very, very quickly and very early on, because you're running on the margin all of the time. So what does that all come back to? It comes back to government policy, which is, over many years, we every November we have discussions with the HSE in respect of their service plan for the following year after the budget. And in that, we always ask a number of questions. What funding are you going to provide to increase bed capacity? And what funding are you going to provide to increase public bed capacity, particularly across intellectual disability, across elder care, and in the acute sector? And also, what funding are you putting into staffing in the public health service? And these are the big battle areas every November, December. And this year, the service plan hasn't been signed off by the HSE as of yet, and it's January. So we don't know the answer to the questions we posed last November yet. The big issue, we believe, is that the care of the patients right now in the middle of a pandemic should not be compromised if there are beds available. So when we say the private hospitals should assist, we believe that what happened early on in the pandemic in March, where the state had access to the private hospitals and to all of their bed capacity, that should be the model that we use. And if we are now in a situation, as we are this evening, across our all of the island, when you look at people who are waiting for beds, where ICUs are absolutely full, where you hear the term surge, where staff are trying to provide ventilation and high-grade support for respiratory failure outside of an intensive care. And if there are intensive care units available in the private hospitals, our view is that they should be available to the people who need them, regardless of whether they're in the public or the private sector. So that is slightly different, I think, to what the HSE have negotiated, which is 30% of care will be available. And what they're using the private hospitals for, which is important also, is to continue with absolutely essential care that is non-COVID. In the meantime, our public hospitals are providing both services, COVID and non-COVID, or are trying to do their very best to do that. And it is important that services are available. We have our ED and our emergencies still attending into our general hospitals. And now we also have a situation where the hospitals are becoming more overcrowded. So again, I suppose just to round it all up, Conor, I'm not saying anything that people don't already know, but I think the ask from our end is, where in the future, when we look back and we say, well, what helped and what didn't help, we believe that the privatization and the policy of privatization of care of the older person particularly must be revisited, must be changed, and we must invest in the provision of long-term care and also step-down care in our public hospitals, in our public system. And that is a policy, and that is perfectly aligned with the Sláintecare model, and therefore it shouldn't be a big ask. So again, the issues for us are right now, they're immediate. It is about getting capacity, getting enough capacity to make sure all the people in the next week, because next week, as we are being advised and the modelling indicates, will be worse. So we have to make sure that our public hospitals can cope with that, and that they need a lot of assistance to provide care outside of their own walls. And we have to make sure the important piece right now is that for the future, we plan, we work together, we remove the political system from the design of healthcare. That's what Sláintecare is about. Sláintecare took the cross-party approach and designed a model that would benefit citizens, benefit those that live in this country. And we support that, and we're calling for that to be fast-tracked, because we've learned a lot after this pandemic in respect of having a two-tier health system. So, Conor, I think that's about as much as I can say right now. I hope that's what you were looking for, but I'm happy to take any questions that you might have.
No, that's excellent, Phil, and I really appreciate you coming along tonight to give us that insight into where things are at. I would encourage just everybody watching at the minute to send in those questions. We will have Phil for another couple of minutes here, but she will have to leave soon to take an interview with TG Carr. I just want to introduce at the minute Professor Veronica O'Keane, who's a member of our campaign, a consultant in psychiatry at Tallaght Hospital. And we'll hear from Veronica in a short moment as well, and she'll speak on this crisis. I guess before I go to questions that we're getting in at the minute from the audience, I guess I'd ask Phil, you mentioned surge capacity in the public system. But what does that actually look like? What does it look like for nurses and midwives, your members that are working on the front line? Because it's obviously not an ideal situation when you have patients that need intensive care being treated outside of intensive care settings. And as you said, there is this capacity that exists in the private hospitals that could be used. So could you maybe give us an insight into what that actually means?
Surge capacity, like it is something that would happen many winters, but obviously not at the level that it's happening right now. It's where, for example, in your theatre departments, in your recovery rooms, you will have space to ventilate patients or to administer oxygen and respiratory supports pre-ventilation. And the nurses who work in those departments, then your theatre departments, your recovery rooms, they would then be operating as intensive care supports for patients. They then have to ensure that they obviously that requires, to become an intensive care nurse is, a postgraduate, higher diploma. There's a lot of training and a lot of experience. You just don't pick that up in a couple of weeks. But everybody tries to do their best in a situation which we're now facing. And we did have some training in March, very sharp training to assist nurses who work in areas and maybe had worked in ICU before, encourage them to come and work in these surge areas, upskilling and refresh to familiarize with maybe some new equipment, etc. So that's what it's like. That's what's going on in hospitals at the moment. People are upskilling. They are working with the support, for example, of an intensive care nurse, might come and supervise, might assist. But it is really day to day, and it depends on the staff and the skill mix as to how many beds can be opened in a surge capacity, and that can change. Today you can have 6, tomorrow you might only have 4. It depends on the staffing that are available and their skills. And obviously you have the support then of your medical teams, particularly your anaesthetists, and that's 24/7. So with the numbers who are being infected themselves right now, this is quite serious, because we do need all of the support of the entire community of healthcare at a time like this, because it's absolutely now a matter of trying to keep people who are very, very, very sick, struggling, alive.
Thanks for that, Phil. We have a couple of questions here just on sláinte care. You said in your intro that the speed of delivery of sláinte care left a bit to be desired. So maybe just go to this question here from Marnie, and you can come back to it. So Marnie says, isn't calling for the implementation of sláinte care a bit unrealistic? Does Phil not think that the progress, even in its own terms, has been painfully slow? It has made way too many concessions to consultants. It has also increased state subsidisation of private healthcare through greater reliance on National Treatment Purchase Fund. Isn't the lesson from the pandemic that sláinte care is just not up to task? So I'm sure we shared a laudable objectives of sláinte care, but do you have a comeback on that, Phil?
Well, I think sláinte care, the model of sláinte care and the design of sláinte care is the correct model. It would be the view that we take, particularly when we look at the objective, which is universal access for everybody at the same time, depending on your diagnosis, not on your ability to pay. And that requires a big change from society. And I suppose the thing that's missing is we have to look at our taxation system. We have to look at what supports that. And those of us and those of you that have lived in other countries where the model of healthcare is different. Like anybody who's lived in the States, for example, I lived and worked in the States as a nurse for a period. And I mean, that delivery model is so stark. And the insured versus the uninsured, and the whole system of healthcare delivery just is dictated by whether you can afford it or not. Nobody wants that model. And, you know, we certainly don't want our very good Irish public health system to diminish in what it does. It trains. It is a huge place to play in training. It trains nurses, it trains doctors, it trains physios, occupational therapists, right across the models of healthcare. And the training that we get in Irish hospitals is second to none. I mean, that goes without saying. The difficulties we face are the funding, and also the fact that if you have private health insurance, you can many times pay a lot of money and still not have access when you have an emergency, because the emergency system is routed through the public hospital system. So Sláintecare, in my view, in our view, we believe that the building blocks are there, that it is the right model. And what now needs to happen is it needs to be invested in properly. There was a transitional fund that should have been that should have been properly funded to get rid of all of the legacy issues that constantly hamper development of the public hospital system. And then you have to have a buy-in from the political system to make sure that our taxation and our model of taxation can deliver and sustain universal healthcare. And that's a big issue.
Just because I'm aware that you have to leave soon, I might ask one final question just in response to that. And we've seen the private hospital deal in the first wave of the pandemic, and I've had unprecedented action from the government where they did things that they told us were impossible before. They lifted a recruitment embargo that had been in place for years, obviously. They injected a massive amount of money into providing healthcare for people based on necessity, medical necessity in the pandemic, rather than insurance status or ability to pay. Was that not a game-changing moment in some respects? It showed that something beyond Sláintecare, potentially a national health service, was possible and desirable.
I think what it showed is if you have an emergency, like the accident and emergency, as it was called, or casualty, as some people might refer to, the route into hospitals in this country is through the emergency department, regardless of your insurance. It's the stabilizer. It's the one area where whether you're insured or not insured, it doesn't matter. You're going to be dealt with based on your need. And a pandemic is just that. A pandemic is if you get sick and you are, and unfortunately, you can deteriorate quite rapidly, well, then you need to be where care can be delivered to you quickly. And and the route into hospital is through your emergency department. So that's what happened. Like if we have an emergency, if we have a road accident, if we have any emergency, the route is through the public hospital system. The Sláintecare model does have a design to allow for 3 standalone hospitals that would only deal with non-emergencies. And that's largely what our private hospitals tend to. There are some that provide emergency services up to 8 p.m. But the Sláintecare report does allow for and promotes the idea that we would have scheduled hospitals that deal with scheduled care, not emergency care. And that is something that we were disappointed in the pace of delivery of that. Now, that would help because that would take the pressure from the acute hospitals that are dealing with emergencies, scheduled care, and everything else. So there's a lot in Sláintecare which has yet to be funded and implemented. And we think that absolutely that those measures that remove that pressure from the acute hospital, like if you take a hospital like Beaumont or James's, where you're getting transfers from every other hospital in the country because you're the tertiary referral centre for in the case of Beaumont, from neuro, and you also are the local hospital for the community around that area. I mean, that means that that hospital is going to be extraordinarily busy, and you have an ED department. So it makes perfect sense that you would have an acute hospital funded by the public service for scheduled care, so that you're not constantly cancelling scheduled care when your ED becomes overcrowded. And that is a model that we would support, that is set out in Sláintecare. And it is very definitely saying, here's a practical way of providing more bed capacity and removing our pressure each time we have an overcrowded ED, which is practically all of the time. And you have to keep cancelling routine and scheduled admissions for necessary elective surgery.
Okay.
Sorry, I hope it answers the question.
Yeah, that more or less does, Phil. It's now quarter to 8. So you did ask me to remind you of that. You're more than welcome to stay on if you like, but I know you've got another interview.
I have to do the speech. Thank you very much, and good luck with your the rest of your meeting.
Thanks, Phil. Thanks for joining us. Appreciate that. See you now. Okay, so thanks again to Phil for joining us there. I guess we'll come to the second part of our meeting now, and we've actually just been joined by our very own Chris Carroll as well, who's a specialist registrar in public health medicine. And Chris, for those of you who might have seen it, is a recent author of an article in Rebel talking about Sláintecare, which Phil just went through there. And maybe when we get to Chris, he might point out some of the weaknesses in our view of that particular approach. I guess now we'll go to Veronica, and sorry to have kept you waiting there for a while, Veronica, before coming in, but you might give us a bit of an introduction. Chris can follow, and then I guess we'll take questions from people who are watching.
Thanks very much, Conor, for inviting me to speak. I'm not an expert in Sláintecare like Chris is, so I'm not really going to address some of the issues that that Phil brought up. But if I could just make a few general points without cutting in on Chris's terrain. And the basic point is, yes, there are, I think, very good elements in Sláintecare. Separating out specialist services, emergency services particularly, from routine medical care is a good idea. I don't think there will be any opposition to that. Expanding the range of healthcare into older age patients who fall over the age of 65 is again a very laudable idea. I don't think anyone's going to argue with that. But the central point, I think, is that can you have equal access if you have private and public healthcare? Yes, ED is a very levelling point of entry into emergency medicine, but it is, if you have a private-public divide, you will not have an equal access to healthcare for routine medicine. It's as simple as that. And I think that's the weakness of Sláintecare, is that it hasn't tackled the public-private divide, in spite of all the laudable aspirations. And I'm not sure, it's maybe the reason that it's being so slow to be delivered is because that particular hurdle is almost insurmountable, i.e. the impossibility of having equal access within a two-tier system. Just a couple of points about COVID that I think are really important to our aims and our insights into how we can achieve an equal and real equal healthcare system with equal access for everybody. The HSE has achieved a remarkable amount. I think we really need to recognise this, how different the management of COVID has been to what I've experienced in the health service in Ireland over the last 15 years. And before that, when I was in Ireland, when I was a young doctor, well, it was simply chaotic then. They've managed to set up a trace and contact system for all people living in Ireland, including non-citizens. We're all being reminded by text if you're positive or restricting. I was a close contact over Christmas, and I got a text reminder every day. I was tested within 24 hours. I got my results 48 hours later. I mean, this would have been impossible to envisage if you've been working in healthcare systems for as long as I've been working in them. We have now developed a nationwide effective system for not only testing but for giving the results. We now are rolling out a vaccine program, and yes, there's a lot of nepotism in it. There's a lot of unfairness in it. I haven't got my vaccine yet, even though I'm frontline. And one would have thought a senior citizen within the health community, but it is going to happen, and I'm not panicking about it personally. So my basic point is that COVID has demonstrated that an efficient and effective national health service can happen very quickly, and mostly that it can happen. And one of the problems that was underlying the pre-COVID healthcare system was underfunding and a lack of beds. Essentially, the access to the private beds has really eased up on the pressure on public beds. Now, one of the mysteries of the current arrangement is that nobody really knows what it is. We knew what it was the first time; it was very clear. I did ask Phil, had she any insights in a written question, but obviously she had to leave. But I really would like to know what the arrangement is. What I know from a consultant's point of view is that consultants can now go from private contracts, private mixed private-public contracts, to just public contracts. And obviously that's a higher salary. So I sort of know from a consultant point of view what is happening, but I don't know if the consultants in the private hospitals have signed up to, who wouldn't have that sort of contract, but who have signed up to a partial public contract. I don't know how many beds are involved, and I don't know what the ICU arrangements are, but it doesn't seem to me that there's anything fixed. So that really worries me, because if it's not fixed, well then are the private hospitals not going to first serve their own needs before coming to the healthcare system, the public health, before serving the needs of the public healthcare system? So I think it would be really good to get some clarification on that, to ask some questions in the Dáil or whatever, if any of us have any contacts to put those kind of questions to the government. I also think it's very interesting that, although with all deference to what Phil has said and to my incredibly busy work schedule at the moment, we have not exceeded bed capacity. We keep predicting that we will, and we have not exceeded ICU capacity. We're actually managing this. And we're probably managing it because there's organisation, because there's a levelling of healthcare, and this levelling has allowed more people to access it in a fairer way. So they're my thoughts on what is happening very quickly and how we can learn from what's happening to promote our own message. I think a last thing to say in relation to what we're saying is the whole crisis has uncovered a problem that didn't seem to exist previously, which is the one of having separate healthcare systems between the Northern Ireland and the 26 counties. I mean, everybody says, obviously, when you have a situation of epidemic, you're dealing with biological and organic issues rather than political and geographical divides, and the two don't map onto each other. And it's completely irrational to obviously to have two separate models of care. First of all, models of care, and secondly, restrictions in two countries, in two different jurisdictions in the same country, actually. And I suppose also with the England, Britain moving away from the EU and Northern Ireland staying a little bit more in the EU, you know, promotes the idea of having a shared healthcare system. So it's a very good time to strike Brexit and COVID. There's a double blow there, really, a double argument there, which I think we can just simplify and press forward with that. I mean, there is increased cooperation. I'm terribly pally with my colleagues in the north. If there's ever a case, I find them incredibly helpful. So there's immense goodwill among the medical community to have a coordinated healthcare system. I can vouch for that personally, certainly from doctors and nursing staff and multidisciplinary teams. Community care is a separate thing, obviously. I guess my last point is simply that I worry and worry and worry about what's going to happen when the COVID crisis is over and we've all been vaccinated, and the whole wave of routine care that patients and individuals have not received comes to the fore. That really bothers me. And we all know that the private patients have access to private care for routine medicine at the moment, and public patients do not. We've heard the ads about the Mater Hospital. Please continue to come to us. You'll be provided with safe and immediate care here. It's on the radio. Every time I switch on the radio, and we have increasing waiting lists in public hospitals. And the less preventative medicine you'll have, as Chris will say, the more ill health will accumulate. I'll leave it at that. I'm happy to take any questions. Thanks very much.
Thanks for that, Veronica. I think you really got to sort of basic issues that we found the campaign on the back of. I guess a realization that it made sense. In fact, it made no sense to have two disconnected healthcare services on a small island of like 6 million people. I guess that was one of the most basic things that we realized when we set up this campaign. And the other was that issue of the divide between the public and the private. And I think we'd all argue in this campaign that the way forward is to have a single tier all-Ireland system, a system that doesn't discriminate when it comes to kind of post-pandemic reality of long waiting lists on either side of the border. I think the best way to address that would be to have a fully integrated single tier system. So we would, as a campaign, go that little bit further than the INMO's stated position. And I think we would support the full nationalisation of public private hospitals. And the one just before I bring Chris in, I let people know we're always looking for new members, new activists in the campaign. So I have shared a link. You should find it whether you're on Facebook, YouTube, or Periscope, a link to sign up to the campaign, and I would encourage everyone to do that. I guess we'll bring Chris in now, but please keep your questions and comments coming. I'm looking at them coming in. We will get to them after Chris has spoken.
Okay, yeah, thanks a million. I suppose what I'll do is I'll just go through, re-emphasize a couple of the points we've already talked about, specifically, I suppose, on the topic of the meeting. And then, I'll go on, I'll talk a little bit about, as you said, the article I wrote for Sláinte Care, around I suppose, the limits of Sláinte Care. And I'm caught off a bit off the hop here. I didn't actually, haven't prepared that piece, but I'll go through it as best I can. I think people can read the article as well, and I suppose it makes it's basically our campaign's perspective on the good points of Sláinte Care, but why we need this campaign as well. So look, on the topic of the nationalisation of the private hospitals, as a campaign, we want a healthcare system which treats everyone equally. And I suppose that's key to everything, really. And I think the current crisis has exposed the inefficiencies and inequities of a two-tiered health system, where private healthcare looks to maximise profit as opposed to focusing on population need overall. And I think that certainly operationally, we should be looking to nationalise the private hospitals to deal with this current crisis that we're in right now. But I think we also have an ongoing perpetual health crisis, which demands that, I suppose, we use the resources that we have in order to, I suppose, meet those population healthcare needs that I was talking about. And ultimately, a two-tier system doesn't make sense. It doesn't make sense structurally where we have now as it stands, we have public hospitals which have some of the highest occupancy rates in the world, and right next door to them we have private hospitals which have vacant beds. We have a workforce, as Philnier was talking about, a workforce that's stretched in our public hospitals and a workforce in our private hospitals which is dedicated to meeting healthcare that can provide profits to shareholders, profits to the private companies, which doesn't make sense when you're looking at, I suppose, an overall healthcare workforce and how best they could be utilized. And then I suppose in terms of planning, like planning it's a massive issue in Ireland, really, is that we don't have good data on what happens in private healthcare in Ireland, and it makes it almost impossible to do population health needs assessments for health services, when you don't have a huge chunk of data. And that's following, I suppose, the logic of the market. You get it doesn't make sense for private healthcare providers to freely provide that sort of data, or even to collect it, if it's not going to affect their bottom line, and it's for a population good, in terms of health service planning. And then I suppose in terms of outcomes, that's the other thing about a two-tier health service. We have we know a lot about, I suppose, healthcare inequalities and health inequalities more generally, where if you're rich, you're going to live longer, and if you're not, you're going to die younger. And I suppose if you're looking at, I suppose, life expectancy, the top quintile are gonna live about 5 years longer than the bottom quintile in men, and slightly less than that gap, but a similar enough gap for women. So while not all of that is created by healthcare inequalities as such, the fact that we have a two-tier system that doesn't treat everyone equally, that exacerbates the problem. And then I suppose finally, we know that for-profit healthcare systems are more expensive and they're inefficient. And we can see that clearly with the United States. 2017, the US spent 17.1% of its gross domestic product on healthcare. That compares to 7.2% in Ireland and 9.6% in the UK. And of their 17.1%, half of that was spent by the state. So the state was spending to fund these private healthcare. They were spending that amount of money, more money than we spend, going straight into a very inefficient and unfair healthcare system that they have. So I think that we have an over-reliance, and increasing over-reliance on private healthcare. I suppose that follows with, neoliberal policies over recent decades, and it creates a vicious cycle where we get these resources, which is money, but also workforce that's diverted into the private sector. And I suppose it's one thing to say that, but also we have to try and understand how we're going to change things. And I might segue now into talking about Sláintecare and the role of this group, because Sláintecare was, there was many good things about Sláintecare. It proposed what we kind of call a beverage type system, which is like the NHS system, where healthcare is funded by general taxation, with an overall goal of creating kind of universal healthcare, which is something we don't have, in Ireland. And the academics that were involved were all extremely well versed in, I suppose, the specific issues regarding healthcare provision in Ireland, and they were some of the most well versed in it, and some of the best critiques that we have of healthcare in Ireland came from the group that were involved in Sláintecare. But it has failed to deliver the change that it promised, and I suppose we need to kind of try and understand why that is. In the article, I give a couple of reasons for that. One, I suppose, is that ultimately, while it's been talked about as saying that Sláintecare was some sort of cross-party consensus, it never really was. It was always it was voted for at a committee stage, but it's very hard for any politician. No politician is going to say, "Oh, I don't agree with universal healthcare." There's always a pretense that you can't say, "I don't agree with everyone having healthcare." It's just not, politicians aren't going to say that. It's what they do that really matters. And so I suppose it was an illusion that all the parties supported universal healthcare. The only party that I suppose didn't support it, in fairness, was I think Mick Barry was the one who didn't vote for it. And I suppose he's proven right in the long term in terms of the concerns that he brought up at the time of Sláinte Care, specifically, I suppose, related to the fact that there was a even if you think there was a cross-party consensus, there was never a cross-class consensus. They never addressed the class forces that have created and reinforced the unequal healthcare system that we have now. They were never challenged. And ultimately, from immediately when Sláinte Care was released, there was an attack on Sláinte Care from, I suppose, those kind of right-wing forces, including, obviously those involved with private healthcare, but also the unions, the IMO and the IHCA. And I think that needs to be noted because it's historically of importance. The other thing about Sláinte Care, I suppose, that I suggest in the piece is that I kind of describe it as a technocratic solution to a social problem. So that idea really is that it had the model that we would agree with. Our campaign's called Campaign for All National Health Service, and that Beveridge style model is something I think which could be implemented both north and south in an integrated manner. And that's opposed to, I suppose, a private model like in the States, or what they call a Bismarck model in some of the social insurance models in Europe. So we agreed with that, and there was thought to be this policy window. So it goes to a work I got by a guy called Kingdon, I think. The idea was that there was this policy window where there was a political will for it, there was the specific issue, and there was an answer for it. The answer for it was Sláinte Care, and that where all those windows align, that then you could get significant healthcare reform. But I suppose what we'd say is that that also implicit in that was the idea that you would take politics out of healthcare, or take healthcare out of politics, and that was impossible. That was never going to happen. And I think it was naive to think that could happen. And I think if we look back through significant moments of healthcare reform historically, they all come about, or they overwhelmingly come about where there's a social movement backing them. So in the piece, I go all the way back to the English Civil War and the Levellers and the Diggers. But I suppose, importantly, what we see is if you look even at the time in Germany, Otto von Bismarck is obviously, he was a kind of a right-wing authoritarian, but he was forced into concessions because of a rising labour movement, which came out of, I suppose, an economic depression in the 1870s. And he introduced the sickness insurance law in 1883, and that was, I suppose, the first building blocks of I suppose of what turned out to be their model. And similar legislation was passed in the UK and France at the turn of the century. And then, obviously, I suppose a clear example would be the social movement that drove the rise to power of labour. There was a huge amount of strike activity, in the period of World War II, post World War II, and that built upon the principles of the Socialist Medical Association and demands of the trade union Congress for universal healthcare. And so I suppose I could go on and give more examples of this, but ultimately what I'm saying is that what was lacking in an Irish context, both after World War II, where there were suggestions that there was a white paper on a Beveridge-style model, and there was a white paper produced on a social insurance model, but they never were implemented. And you can say, and there's a reason for that, and they were opposed, obviously, by the medical profession, the Catholic Church, but there was never a social movement demanding them either. So I think there's lessons that we can learn there. I'll finish up at that, and but yeah, I suppose we do need to have a principled stand on, I suppose, a moral question, which is it's morally correct that everyone should get equal healthcare, but we also need to have a kind of strategy which will include a social movement, and that requires left parties and trade unions to, I suppose, get involved in that demand for universal healthcare.
Thanks for that, Chris. That's really comprehensive, I think, on sláinte care. But I would encourage, because there's a lot to digest in one go, I would encourage everyone to check out that article that Chris has written on behalf of the campaign on sláinte care, where he draws this out in a bit more detail. I guess we'll go to questions now from the audience. But before I take one there, I maybe want to just start with another kind of question about sláinte care, because there is actually in the implementation of sláinte care, a product of this, the Butler report, which basically aims to take private medicine out of the public system and aims to untangle the kind of linkages that exist between the private and the public. There's a great deal of those. I mean, private hospitals, if you want to build one, there's all sorts of tax incentives that the Irish state have created that you can avail of. There's obviously tax incentives for people to take out private health insurance, in addition to, I guess, the incentive of the inadequacies of the public system and the whole queue jumping argument for private health insurance. Let's maybe ask the two of you, what do you think would happen if the private system were to become decoupled from the public? Would it live? Sláinte care does leave that room for the continued existence of the private system, just in a very different way to the way it exists today.
Yeah, well, I suppose what I say about that is interesting. You talk about the Butler report, because that was one of the ways in which I suppose, and it happened with the program for government as well. I think we saw it in which important reviews or important decisions that kicked into a review. So the Butler report, I can't remember which hotel it was, but it was when it came out during the summer. I don't know if it was the Alexandra Hotel, or I'm not sure where it was, but it was buried anyway. There was no representative, there was no ministerial representative there at its launch, advising that obviously the private healthcare should be taken out of the public system, and all with an understanding of all the kind of perverse nature of the system that we've created, that it should be undone. But I think ultimately what in sláinte care, it tries to, it was a positive idea. The idea is basically you build up a public healthcare system which is so good that people stop paying their private healthcare, and that so that you no longer need that. And then the idea was then at a population level, while you need this investment and this continued investment in the public system, that the money that's been paid into private insurance as it stands would then be diverted would no longer go into that. So it wouldn't mean that overall that our general level of taxation or a general level of healthcare spending would rise exponentially. Rather, there would be a shift from private back into I suppose the public. I think that idea is basically that it's kind of like a withering away of the private sector as a result. And I don't know if that's ever going to be possible. I don't know if that's possible, but certainly if it is going to be possible, then you need to understand, you need to address, I suppose, you need to address the kind of class, the class antagonisms there, and you need to, as you said, the current way in which, I suppose, following on from, there were important changes basically since the early 2000s in the way in which tax incentives have been have promoted private hospitals and private healthcare, and you'd need to look at reversing those, and you'd need to look at but that won't come without a struggle, because there's always going to be antagonism from the, I suppose, the capitalist class in that instance, but whatever class benefits from private healthcare.
Yeah, that's an important point, I think, and I might maybe phrase the question a little bit differently to you, Veronica. Seems you're a consultant, you have extensive experience working in the health service. What do you think the response to from consultants would be to the gradual decoupling of private and public, and how can that be challenged? Is there a way to convince consultants, or what is the path forward? And how do we kind of build those struggles that Chris so well points out are necessary?
Well, first of all, I do think we can have a single-tiered equal access system in Ireland. I've seen things change over the course of my lifetime that I would have thought impossible. Look how COVID has changed everybody's lives on Earth. So things happen, things change. Life is always changing. In fact, if things aren't changing, the world would be dead. So I do think this sort of an organization, we're starting at the very baseline, and we do need to increase public awareness and public outrage, really, at what's happening. So I think Chris is very right. We do need to inform people and get them motivated. We can use the familiar left-wing institutions, but we also need to move beyond that. We need to inform people about the inequalities, because I'm not sure people understand that. So there are so many levels. This project is only starting off. It's an acorn, and we want an oak tree. So we're going to have to just chip away at multiple levels. The distangling from public and private is going to be immensely difficult, because consultants and the state have always been in cahoots with each other to maintain private medicine within public hospitals. It's a complicated system that goes right down to the Catholic Church and the Church of Ireland sometimes, obviously, controlling healthcare. And the consultants sort of did a deal, said they would accept the ethos of Catholicism, and the nuns allowed them to practice private medicine. So, the religious orders and the medical consultants made a very powerful, they had a very powerful presence in Ireland. The power of the church obviously has dismantled. They're still very wealthy, but I think probably the last big church control of medicine has been played out in the new maternity unit, the obstetric unit that's going to be built on the St. Vincent's Hospital site. So that's kind of out of the way, but slightly. We're moving out of that. But we're not moving out of the neoliberal politics that have always existed. I don't think they're new very much in Ireland within medicine. And that's going to take a fair amount of convincing. But, I don't think most people do medicine to get rich. That's one thing. And I think if you can sell medicine as being something, that's really positive, not what you can do for your country, but what, not what your country can do for you, but what you can do for your country. There is that aspect to medicine. And, most young people are fired up by that. I'm cynical. So, but I can, I'm tired of healthcare systems, but I still have that burning desire to, fundamentally help people and bring people from sickness to good health. And I think most doctors share that. So yes, it's going to be immensely complicated, but we need to build up, I think, zeal, goodwill, and give doctors, I think doctors have much better training now than they did in my day. They've much better working conditions, they've a limited work week, but there's still an awful lot of room for improvement there. The nurses do need to be paid, as we've spoken previously. So I think on every single level, we can sell a public healthcare system. We can sell it on the grounds of not burning people out as well. Your sense of well-being within a healthcare system that's functional and that's fair, and that's fair to the individuals in it. Your own sense of well-being improves when you're working in a functional, fair healthcare system. So it's massively complicated. It's complicated at the level of, collective memory, of collective goodwill. But I think that, we can only start from the bottom. We're the acorn, and we've a lot of work to do. But I think that this idea is a very powerful one.
Absolutely. And I guess just to take the opportunity there to discuss a little bit about the campaign. We've been on the go now for quite a number of months, but what we've been doing, we've obviously been limited by the pandemic. We can't have any massive marches or anything like it, unfortunately, as much as we'd like to. So over the last couple of months, we've been gathering support of a very broad mix of organisations, political parties, trade unions, trades councils, and even county councils. Last night, of course, we had a motion before the councillors of Dublin City Council calling for an All-Ireland NHS and calling for support for this campaign. So we that motion last night was deferred, as we've talked about. But we have secured the support of a vast array of organisations. And to anyone watching, if you represent, whether it's a patient activist group or a political party or a trade union, we'd encourage you to reach out to us about how you can get involved and how you can help us bring this idea forward. I don't think anyone has a monopoly on this idea. I think it's something that we're all going to have to bring forward together. And it's going to take a serious social force to deliver. I guess I might just go back again to the issue of, you touch on here the kind of motivations of doctors and other carers, why they get into the profession in the first place. One of the big issues, I think, is the issue of contracts. It's something I think you have mentioned before, Veronica, and public-only contracts in particular, the lack of decent public-only contracts for medics. We've talked before about how almost 50% of the medical workforce are foreign-trained doctors, and they have no access whatsoever to become consultants. What would you think, Chris and Veronica, is the way forward there? How do we train this new generation of doctors to be public-only, and I guess the carers that we need in a National Health Service style system?
Well, maybe I'll lead with that because I've more experience in the area of training. I think the consultant contract is very, very good. Doctors at a senior level get paid extremely well, and so I don't think it's a lack of remuneration that's causing whatever disaffection is felt by doctors. I think it's more frustration with the public healthcare system. It's disjointed. It's not joined up. In other words, another way of putting it, it's deeply unsatisfactory to work in a system in which you're trying to get things done and you can't get things done. And we're always at the mercy of whatever minister is in power and whatever daft notions people might have. And people have a lot of notions about healthcare. I've for the last 10 years, this idea of recovery has dominated in psychiatry. It's not a new idea. It was always there. We always tried to bring patients to as far a point as we could in terms of their wellness. It's a very old idea. The reason we didn't do it was because we had no resources. We had no psychologists. We had no OTs. So it's politics. They're usually using an idea to promote what should be a normal healthcare system. And they're limiting our means of treating patients with all these ridiculous policies. I know in anesthetics, for example, they often can't work because of limitations on from hospital management and from the HSE. So whatever area of medicine you're talking about, there are these very frustrating obstacles that are very difficult to transcend. So I think a lot of consultants go into the private hospitals because, we all like having money. There's a reward there. There is something there that is tangible and that is satisfactory. And they do provide good care. If consultants had the possibility of providing that care in the public system, they'd be much less likely to double job, as it were, which is what I look on the private contractors being in largely. So that's one aspect. So I don't really think it's remuneration. I think it's lack of efficiency, lack of coordination, and the training pathway, which is unfair for foreigners, for non-nationals. But you know, I would say there's increasingly less disadvantage to being a foreign national in the system, and we are also giving, and that's evidenced by giving doctors now who complete their medical degree a place, because there is a recognition now that we need more junior doctors. So doctors who are non-nationals now are getting their intern years, their first clinical training year in hospitals, and that's a real. There was a horrible situation previously where you had people who were, you know, you trained with them all during medical education, 6 years, and then they weren't allowed to work with you. It was really unfair. That has changed now, and I think we should put pressure on the government and on healthcare systems to maintain that new way of working with doctors post training. So yeah, I think it's what we're presenting people with, and I think if we present them basically with a better package, a more satisfying, more equal work package, that they would be happier to move away from private care.
Thanks for that, Veronica. Do you want to come in on that one, Chris, as well? I guess just when I was phrasing the question initially, I didn't mean to get towards remuneration. I think the big issue is that issue of control, that there are consultants that have the luxury of working across both systems and, as you said, double jobbing. So I guess, how do we get to a situation where the majority of doctors, and I think you're right in pointing out, if the conditions were better inside the health service, it could well be more people willing to work public only. But how do we get to a situation like that? How do we transition towards a system where there are enough doctors? Because those ones that have the right to practice private medicine, they have an immense amount of power, and I think we'd be remiss if we didn't see that power as a fundamental obstacle to the realisation of public system.
Yeah, I mean, sorry, I didn't say it, but obviously we need to move to a situation of abolition of private public contracts. Sorry, that was a given. But thank you for thank you for clarifying it. I don't think it's ever going to work, because you know, human beings are driven by the incentive of making money. Yeah.
Absolutely. Any thoughts on that one, Chris?
Well, yeah, I think you're right to raise the issue, I suppose, foreign doctors and their treatment, and that we as a campaign need to support them, I suppose, in with regards to, I suppose, training and then staying and provide, and you know, staying and continuing to work in the Irish healthcare system, because we are seeing a lot of them where they're, you know, it's a lot of the time is that they do a huge amount of work, often in hospitals, you know, regional hospitals, where they can't get you know, it's not maybe the hospitals where it's the most attractive if you want to if you're moving around the country to work in, and the backbone of a lot of our hospitals are doctors who've trained abroad and come here. But what I'd actually like to, I suppose, what I think should be really emphasized is I think that we do need, I suppose, to promote the role of other healthcare workers. I think that there's a huge power in that. I think if you look at the move for Medicare for all in the States, it's largely been driven by nurses, and I imagine that any movement here, any social movement of a size, would be the same. And I think that also, I suppose, we need to maybe reconceptualize what we mean by health and healthcare. And I think that from the outside, especially because, you know, and we're playing into it here a little bit, but from the outside, I suppose a lot of healthcare, you know, there might be an idea that doctors are by far the most important or anything like that, but that's not necessarily the case at all. You know, health is more, healthcare is more complex than that, and certainly from the foundations of medicine, like evidence-based medicine, isn't around that long in the historical, I suppose, in our historical context. And before that, the people who were doing the only care that actually made a difference were people who were doing caring duties and nurses. So I think that we need to emphasize the role of all healthcare workers, really. And I think that especially because of the compromised class position of doctors, I think that we really do, any movement for universal healthcare will require, I suppose, kind of that the voices of others.
Absolutely agreed there, and I think we've seen that potential power really borne out 2 years ago, almost to the day, when the INMO went out on strike, and when they called the march, 30,000 people joined them on the streets of Dublin and got behind them. And even though it was a short-lived strike, I think it showed us the immense moral authority that nurses and other care workers have, and I think scenes were repeated to maybe a slightly lesser extent when other allied healthcare professions went on strike a couple of months later. So that's definitely something I think that we've been trying to draw out in the campaign. Just before Christmas, we actually had an interesting sort of internal discussion with healthcare workers of all shades, where we discussed the role of, I guess, workers within the health service and kind of transforming it. So just again, to anyone watching, this is something we hope to bring forward on an ongoing basis. We do hope to revisit that and have another meeting to organise it in the healthcare unions. So I think, like Chris said, we will need the organised force of those other healthcare workers in the aside from doctors to drive this forward. I might just ask another kind of topical question, or I guess relates to our overall theme of nationalisation. You may be touching it a bit there, Veronica, when you were giving the historical perspective and the role of the church. The church are still major players in Irish healthcare, obviously, particularly private healthcare. The Bon Secours Hospital Group are the largest private healthcare organisation in the entire country. The same order that were behind the Mother and Baby Home at Tuam. And now we've obviously seen calls for redress and the conversation around the Woods deal and the way that the state indemnified the church for its legacy of abuse and other things. I guess how do we as a campaign maybe relate to that demand? I guess we have called, in light of the Mother and Baby Homes report, for the nationalisation of those church-owned assets. But how do we begin to address that kind of legacy of the church and in Irish healthcare?
Make them pay. That hurts. So I would say, you know, if we're going to zoom in on one point, and people like things to be crisp, we should say that these are wealthy organisations, that they should pay for the redress 100%. Yes, all of society is responsible. We all turned a blind eye, everybody did. But I guess it hasn't hurt them very much financially. You know, they still have vast wealth. So I would say, yes, make them pay. And I think there's quite there is a high level of awareness of the damage that the Catholic Church has done in health and in education. And I kind of feel that has a momentum of its own. So in terms of what we do, we put in, I would say that we should strategically, you know, obviously we just say what everybody else says, the corrosive influence and the cruelty and so on and so forth. You know, it's a given that we see all this and have good insight into it, but I think we should hit them harder and more specifically and just say, you know, what have they paid for? What have they paid for? They haven't really paid for anything and they still have loads of money. So hand the redress system over to them. But we implement it. I mean, they hand the responsibility for that, for coughing up the money to them. And yes, the government and the citizens of Ireland will monitor that, but we shouldn't have to pay for it, like we've done for previous abuse by the church.
Absolutely.
That would be my take on it anyway, from our point of view. Yeah, I don't know if Chris has any ideas.
No, I don't really have anything to add. I think that's covered it really. But no matter who it is, I suppose, you know, if it's the church or if it's Dennis O'Brien or Larry Goodman, I suppose we're dealing with, I suppose, class forces here and the class nature of healthcare. And I think that has to be fundamental to our analysis of how we're going to, you know, strive for universal healthcare. Because, yeah.
I think it's interesting just to look at how the influence of the church within healthcare has shifted and changed over the decades. Like, again, the Mother and Baby Act, or the Mother and Baby scheme that Noel Brown tried to introduce in the 50s. The church were a major obstacle to the introduction of that. They talked about socialised medicine or socialist medicine in some cases, and tried to whip up, I guess, a Red Scare almost, the idea of free care, even in a very limited context for mothers and their children at the time. But now it's kind of different, isn't it? It's like the Bon Secours Hospital Group, the major kind of corporate players on their board. There's not very many nuns from the order in the mix anymore. Instead, what you have is a former chief executive from AIB and a partner from PricewaterhouseCoopers. Maybe just comment on the kind of changed landscape of private healthcare in Ireland, because I think it's definitely evolved over the last 2 decades. The influx of foreign capital as well, the Universal Health Group from America and others, they're now at the table. So where do you see, barring the success of our campaign, where do you see private medicine moving in Ireland? What do you think its goal is? A sector that is continually growing outwards. What is their end game?
What is the end game of the capitalist class? They want to. I mean, it's shocking. It really frightens me when you see the list of names of the people who own the private healthcare and who control it. It's the same people who control everything else and who own everything else. So it's become a product. You know, this is the healthcare market. It's a product, and you know, it's as Chris would say, health is about well-being. It's about public awareness. It's a much broader thing than just a product like mending a broken hip. And it's really only when you look at, sorry, I have something caught in the throat. Maybe I'll hand over to Chris. Sorry.
Yeah, I suppose I agree. Like, it's what they found, I suppose, is internationally, I think healthcare has got very high returns on investment. They have a high profit rate. So there has been, you know, it's just natural. That's how the system works. You know, that there'll be an attempt to further commodify healthcare as much as possible, because it is too big to fail. And I think we've seen that in the UK with some of the PFI schemes, the private investment initiatives, or I might have got the acronym wrong there a little bit, but where we have seen the private sector take over and I suppose the building of healthcare facilities and the provision of them, that where they can't do that, they fail and the state has to take over again. We've seen that to a lesser extent here, where we have seen private healthcare fail in, I suppose, the community especially, and the requirement of the state to step in, whether that be financially or with other forms of support. So I think that's the nature of things. I think I had another point, but I've kind of forgotten it now. Yeah.
Thanks, Chris.
Yeah. Sorry, I'll just be 30 seconds. A very good example of the limitations of private healthcare and how they throw people out when there's no more profits to be made is within psychiatry. Luckily, in psychiatry, private and public healthcare are actually fairly separate. The private healthcare is really only in the private hospitals. But if the private hospitals receive an unfortunate individual who goes on to experience a psychotic disorder, a severe psychotic disorder, it's a lifetime health issue for them. And the public hospitals, or the private hospitals like St. Pat, St. John of God's, they discharge patients after 6 months and they send them over for public health care. So they don't manage chronic illness. They're getting all the money for the acute care, but they don't hold on for the long haul. So it's bad medicine, actually, for a lot of things.
Yeah, this is a point I think that was made in the comments section earlier on by Anthony Staines in response to something that Chris said, and I think he put it quite well. He said that there's always a real risk of the private sector cherry-picking profitable services. So it does, I think, undermine care fairly fundamentally. We're getting to an hour and 15 minutes here, so I might take just one more question. And we kind of dealt with it already, but I'll ask it anyway and see if you have any fresh perspective on it. It's from Kieran McNulty, and Kieran asks, universal free public healthcare surely means that private healthcare has to be totally closed down in Ireland. So kind of in light of what we've just sort of discussed here, how that sort of existence of the private system undermines care, do you have any thoughts on that?
I agree.
Great. Me too.
I think so, but like ultimately, we're not going to be, us three are not going to be deciding what's going to happen, so it's all about, what's going to happen with a kind of social movement that demands universal healthcare. I think we've made the arguments around private healthcare, why it's inefficient, why it's inequitable. As Anthony Staines was saying there, there is this idea of the inverse care law where you submit healthcare to market forces. It leads to health inequalities. So that'll always be, I suppose, I think we have a clear kind of critique of it. And the fact that it does still exist in, say, like the UK to a far, far smaller degree, or in other countries where they have instituted universal healthcare and had universal healthcare reforms, that a small private sector still exists. That has happened, but I suppose, yeah, we kind of have made our kind of critique against it.
Yeah, I guess it was a point worth drawing out, I think, because again, we are something different to the approach of Sláinte care, I guess, and like I think that basic clarity of the need for a fully public system is something that we had that will be at the heart of bringing that type of movement into being. So I guess we're up on an hour and 20 minutes now, so we might leave it there. So I'd like to just thank again Veronica, Chris, and Phil for speaking earlier on. And to anyone watching, again, I'd encourage you all to reach out to us. We have a form if you want to get involved. I'd encourage you to fill that in. And we have a petition that we're trying to build support around too. So if you all follow us on social media, you'll be able to keep up with us. We do hope to bring a movement for an all-Ireland National Health Service to the streets as soon as it's safe and possible to do so. So thanks everyone for watching, and we'll leave it there.